Our next speaker is Dr. Nir Eyal. Dr. Eyal is professor of bioethics at Rutgers and previously worked at Harvard for 13 years. Dr. Eyal has worked and studied in a wide variety of departmental settings, including philosophy, policy, law, arts and sciences, medicine, and global health. I'll highlight here that some of the areas that Dr. Eyal has focused on are population-level bioethics, a field which he co-founded, research ethics, challenge trials, and consequentialism. Dr. Eyal, please.
Thank you so much. Can you hear me?
Yes, perfectly.
Fantastic. Thank you so much to the organizers for inviting me, for including a discussion of challenge trials in this important panel. Again, challenge trials are a way to test, in the context of vaccine, a way to test whether the vaccine works by exposing people to the virus. After some of them got the vaccine, some of them got control. The control could be another vaccine you're trying to compare. It could be a placebo. It could be a different dosing regimen for the same vaccine, if that is what you want to compare to the regular dosing regimen of that vaccine. It could be many things, but basically you check the efficacy of that vaccine, not by vaccinating some, leaving some at control, and then sending them back to their homes and waiting for months for some of them to get naturally exposed, but you actually intentionally expose people to the virus, which sounds very provocative. Millions are dying because of exposure to the virus. How can it be ethical to expose people deliberately to such a virus so that you can accelerate finding answers to questions? One answer would be in terms of something like the trolley problem mentioned earlier. There are so many beneficiaries from the use of challenge trials to discover new vaccines. As just mentioned, there are new vaccines. Even now that there are several authorized vaccines, there are other vaccines that would be easier to deliver, easier to purchase. And these are important to develop and develop fast to save many, many, many lives. But there are also other answers. In fact, challenge trials, if you do them right, need not be very dangerous for study participants, and they can come with their full consent, something that you don't have in these trolley scenarios just mentioned from an ethical standpoint. So here's what I have in mind. If you want to have a challenge trial, if we had the wisdom to develop viral culture back when we heard about the virus in January 2020, or when in March 2020, articles started to come out saying that we should consider conducting challenge trials to test vaccine candidates. I was the lead author of the first peer-reviewed publication that proposed that, and there was also a memo back then circulating at NIH. We now know, calling on the leadership of NIH to conduct a trial. If we had the wisdom to start developing the culture, it's a process that takes 3 to 4 months. Maybe a few months later, we could have started the dose escalation process that leads to a challenge trial. And by now, we will have had data coming out of challenge trials. They are better tools generally for confirming outcomes of the impact of vaccines on infection and infectiousness rates. They are better for developing, for discerning the correlates of protection, something that we still don't have very good information on about the authorized existing vaccines. So we could have had a lot of that information maybe by the end of last summer, the fall, and it could have really promoted public health interventions around the world. And it also could now serve to develop new vaccines that we still need faster so that the entire world can benefit from the power of vaccines to fight COVID. Why am I saying that it's easier to justify than in the basic case of the trolley problem that we mentioned earlier. So it's not just that there are many, many, many lives that one could save by sacrificing one. Another component of this is that we're not really sacrificing any one identified life. First, there's no identified life. Even if there is a risk, we don't know who is on the losing side of the trolley tracks. We don't know it will be you who will lose. And that for some ethicists makes a lot of difference. It's only taking a risk. And secondly, the risk turns out, if you select your study participants in a smart way, to be very, very small. Why am I saying that? Because this disease is very sensitive. Severe COVID outcomes are very sensitive to whether you are young and healthy or alternatively much older. And we have run the numbers, and multiple papers have now confirmed that the risk of death in a challenge trial for COVID would be something like 100 times smaller than the risk of death from an intervention like right liver lobe donation, which doctors very readily perform. It's described in NHS documents, documents from the leading medical suppliers in the US as a low-risk intervention. And we are willing to do it, to ask people, please give us a liver lobe with some risk of mortality, also 20% risk of some morbidity. Not because it's in any way good for the donor's health, but because it's very important for one other person's health. Well, if we're talking about trials that would be important for millions and millions of people, maybe billions of people, it's overwhelmingly justified in that way. So again, unlike in the trolley problem where I will kill this one person, you absolutely do not know that you will kill anyone. And secondly, you don't know which one it will be. So the risk for any one participant remains very small indeed. There are also far, far, far fewer participants needed in a challenge trial than ordinary field trial of the kind that we witnessed with 40,000, 60,000 participants in the past. We're talking only about 50, 100 participants, and the risk that there will be any accident in that trial, given that the individual risks to each of the individual participants is very small, is indeed also quite small. Another way in which this differs from the trolley example mentioned earlier is that these people consent. In the trolley example, nobody consented to being put at risk. You just need to make a difficult choice and decide who you will sacrifice, although they do not want to die. In the case of challenge trials, 40,000 people have volunteered to participate in challenge trials now that have now the preliminary stage for which has started in March in Imperial College London, and that is pretty much the same number as the number of people who have volunteered on a website called onedaysooner.org earlier on, and declared we would be interested in taking that risk ourselves so that we can help others a lot. And with consent, one other reason why doctors are perfectly happy to take kidneys, liver lobes, other organs for transplantation for people to serve others who would benefit more from that, is that they get the consent of these individual donors. So here we also have consent, and it could be very high quality consent if we do the consent process as we should. There are other trials where participation is not good for your health. It's actually somewhat bad for your health. For example, the toxicity trials on new interventions, vaccines, treatments, which are often done on healthy volunteers. They don't need in any way the exposure to the small dosage, not therapeutic dosage of, say, the treatment that we're want to examine. And they could be harmed if it turns out to be toxic. And they're willing to take that risk. And we are willing, because they consented, to let them take that risk. Challenge trials may also give rise to other concerns. I'll mention maybe two more before I finish. One is the concern that the data we glean from these trials are not really helpful to us not because they're not generalizable to populations beyond the healthy young volunteers who will participate. We are protecting old people from participating, which would be more risky for them, but thereby we don't learn anything. The critique goes on the vaccine effect on all populations. But there are multiple responses to this, and one of them is that challenge trials are fantastically generalizable, actually, in an indirect channel. So here's what I have in mind. Challenge trials, everybody agrees, including opponents of challenge trials, everybody agrees have better capacity to discern the correlates of vaccine protection. These are specific immune system changes that were discerned only in those participants in the challenge trial who got the vaccine, not control, and the vaccine worked well in them. There was no infection in them. These very specific changes that were not observed in these same individuals beforehand are very good proxies for the processes that enable the vaccine to work in the body. Once you get good correlates of protection, which we currently do not have very much for the vaccines that have already been tested, because it's much harder to discern the correlates of protection in field trials than it is in challenge trials. Once you have the correlates of vaccine protection from infection, you can do a follow-up, very benign, very short study with many participants that can check both the safety of the product, something that challenge trials don't give us interesting information about, and check whether just giving the vaccine, no viral exposure, just giving the vaccine generates these particular proxies, these particular correlates of protection in a population that you studied. And you can study old people, you can study people with this kind of kidney disease, with that kind of kidney disease, you can study people of different races from different geographical areas, different ages, children, because it's safe. You just give them the vaccine candidate that you've already tested in multiple rounds beforehand, and you only check very briefly afterwards whether it sparked that correlate of protection. So this way you can really generalize in a very high resolution way, in a very safe way, thanks to the findings from the challenge trial. And it gives you, it resolves the generalizing challenge that otherwise we face both in challenge trials and to some degree in field trials as well, because there's a limit to how granular the subgroups in the analysis can be. Final issue is there have been worries that challenge trials would undermine public trust. We know that we have a huge problem with vaccine distrust in the public. The response to this is it's really based on just speculation. The only empirical work to try to test how much the public would react adversely to the reliance on challenge trials is from empirical studies. I was involved in the larger one of these, and it showed in 8 countries an overwhelming majority of people in favor of challenge trials if they could get us vaccines faster than conventional trial designs. And in the UK, where there is the ongoing beginning of a challenge trial in Imperial College, Oxford University is now planning another challenge trial. We have observed no decline in vaccine confidence. And in fact, the UK continues to have much more confidence in vaccines than other countries, say in Europe, like Germany, where there is much greater vaccine hesitancy. So really no empirical foundation, I think, for the claim that challenge trials that help us show very effectively that vaccines work would somehow undermine public trust just because of the ethical controversy, for which we anyhow have very good responses. So I'm looking forward to further discussion.